Thank you very much. It's a great pleasure to be here. I have some conflict of interest. As Julien emphasized also for MR, there is an indication in AS when the aortic stenosis becomes severe. And this is why it is so important to have an accurate quantitation of the aortic stenosis severity. And the main parameters of AS severity that we measure by Doppler echocardiography, you have the peak jet velocity, the mean gradient, and the aortic valve area. And when the peak jet velocity is high, more than 4 meters per second, the mean gradient is higher than 40 millimeters of mercury, and the valve area is small, less than 1, well, this is obviously a severe AS, and if there are symptoms, there is a class 1 indication for aortic valve replacement according to the guidelines. This is easy. But up to 40% of the patients actually have a discordant grading at their echocardiogram, which is actually a valve area that is small, that is less than 1, consistent with severe AS, but with a low peak jet velocity, a low gradient, consistent with non-severe AS. And actually you have three categories, three subtypes of patient in this discordant grading with low gradient. You have the classical low flow, low gradient with the reduced LV ejection fraction. The paradoxical low flow, low gradient is the case where you have a preserved LV ejection fraction, but nevertheless a reduced stroke volume and flow across the valve. And also you have patients who have normal EF, normal stroke volume, but still this discordant grading with the small valve area and the low gradient. And we call them normal flow, low gradient. So let's start first with the valve area. First, it is very important to differentiate, to distinguish the anatomic versus the effective orifice area. This is not the same measure. This is not the same physiologic parameter. The anatomic orifice area is what you measure by planimetry if you have a good image quality. This is the area of the valve orifice. And it is different from the effective orifice area, which is the vena contracta of the transvalvular flow jet. And it is important to remember that the effective orifice area that we calculate by the continuity equation will be always smaller than the anatomic orifice area because you have a flow contraction downstream of the valve orifice. So this is the continuity equation that you have here, where you have actually three measures: the cross-sectional area of the LVOT diameter and the velocity time integrals in the LVOT by pulse wave Doppler and across the aortic jet by continuous wave Doppler. And of course, the crux measurement in this is the LVOT diameter. Smaller error in the LVOT diameter will result into a large error in the aortic valve area because the LVOT diameter is squared in the continuity equation. First, when you do this parasternal long axis view by 2D echo, it is important to get the right imaging plane. And you want to have a plane that bisects the right coronary cusp anteriorly, but posteriorly, you want to have the imaging plane that is at about the commissure between the left and not coronary cusp. So you want to have the imaging plane aligned with this double yellow arrow. If you see well, if you see too well the cusp posteriorly, then this will probably be an indication that you have a truncated view that is more like with the double arrow, and you will underestimate the LVOT diameter, whatever you do. Once you get the right imaging plane, such as this one, which is a little bit off-axis, where you see well the right coronary cusp again, but you are the commissure posteriorly, then you need to measure the LVOT diameter at the right place. And of course, there are some confusion in the guidelines where to measure the LVOT diameter. But what I would suggest is to measure it at the aortic valve annulus, where it has been originally described, so at the base of the aortic valve cusp, so like the double yellow arrow, or very close to the annulus at the level of the membranous septum. You don't want to be too much at the level of the septal bulge, which is frequent in this patient, because you will underestimate the LVOT diameter. One tip that you can use is this simple formula, which predicts the LVOT diameter according to the body surface area of the patient. Very simple formula. And if you are 2 millimeters smaller or more, or larger, then this is probably an indication that you underestimated or overestimated the LVOT diameter, and you can reassess the measurements. The other thing I like to use is the Doppler velocity index, the velocity ratio, which is a simplified version of the continuity equation, where you actually remove the cross-sectional area of the LVOT, which is the challenging measurement. And so it's just a ratio of the velocity time integral. And if both parameters are consistent, severe or non-severe, you're good to go. But if, for example, the valve area is smaller than 1 and the Doppler velocity index is 0.3 or 0.35, there is something wrong, and probably this tells you that you underestimated the LVOT diameter. So the other thing you have to pay attention is the calcification of the aortic valve and the LVOT, which are frequent, of course, in patients with calcific aortic stenosis. For example, in this patient, you have a calcification bar extending posteriorly in the LVOT. And of course, it is tempting to measure, like here, from the, let's say, the white line to the white line. But actually, if you do this measurement like this will grossly underestimate the LVOT diameter and therefore the stroke volume and the valve area. Actually, the right measurement is this one that exclude the, or include, depending on where which side you are, the calcification that you see here, this huge calcification here. And you see the difference in terms of valve area, you have 0.4 centimeter square difference. So given the limitation and the challenge in measuring the LVOT area by 2D echo, as we do routinely in the echo lab, some people have proposed to use an hybrid method where you measure the LVOT area by CT or 3D echo instead of measuring by 2D echo. And then, of course, you use the velocity in the continuity equation like as usual. So again, the LVOT area will be obtained by the 3D imaging modality, CT or 3D echo, and the velocity obtained by Doppler. And this method has been applied, should say, retrospectively to a series of patients who have undergone TAVR for severe AS by the group of Camperidis and colleagues. So this is the group in Leiden. And actually, using this hybrid recalculated valve area, they reclassified 16% of the patients from severe to non-severe. Most of the patients were in the low flow, low gradient, normal flow, low gradient. But there were also, which is more intriguing, some patients with high gradient reclassified to non-severe. You have to pay attention, however. When you have a new modality that measures valve area in maybe a different way, it is important to validate the severity cut point, because in this study I just showed you, they used the cut point of valve area of 1 to define severe AS. But actually, Marie-Annick Clavel did this study where they look at the impact on mortality in medically treated patients. And the cut point of the valve area, the standard valve area that we measure by echo, to predict mortality was less than 1 centimeter square, which is consistent with the guidelines with the standard valve area. But with the hybrid valve area, which is somewhat larger, well, the severity cut point was larger, was 1.2. And if you use this cut point, the 1 centimeter square for the echo valve area and the 1.2 for the hybrid valve area, you predict very well mortality with the same accuracy. So we kind of, through a letter to the editor, applied retrospectively this validated cut point for the hybrid valve area. And if the authors had used the 1.2 instead of the 1, they would have reclassified 3% of the patient, and none of the patients with high gradient would have been reclassified as non-severe. And most of these patients were in the normal flow low gradient group. So another caveat is when you measure the peak jet velocity and therefore calculate the mean gradient by continuous wave Doppler, the most important thing here is to really be sure that you get the maximum velocity. And you need to achieve this goal, you need to have the Doppler beam very well aligned with the direction of the flow. And this is why it is so important to do a careful multi-window interrogation. And it takes time. If you only interrogate the apical 5 and 3 chamber view, well, you will get the maximum velocity in about only 40% of the patient. So the right parasternal border window is extremely important because you will get the maximum velocity in 50% of the case. Also, the suprasternal notch is important too. Having said that, in the right parasternal border, because you often have a more background noise, you may overestimate the velocity time integral. This is an example here where you see the sonographer has been a bit generous in the tracing, and the sonographer went beyond the click, the closing click that you see here, and went into diastole. And so the aortic velocity time integral was 75 centimeter with a valve area of 1.16. But actually, the tracing should stop at the closing, at the aortic valve closing click, and therefore the VTI is smaller and the valve area is larger. It's about a 0.2 centimeter square difference in this case. Another pitfall caveat that may result in overestimation of peak velocity and therefore gradient and underestimation of valve area is this issue here. We have a not very good continuous wave Doppler signal with kind of some incomplete envelopes in some beats, but we got a peak velocity of 2.86, a mean gradient of 20, peak gradient of 33, which would be about moderate AS. But in the apical three-chamber view that you see here, well, the gradient is much lower, about twofold lower. Bizarre. Well, why? Because this is not aortic velocity. This was a TR velocity. And you may, once upon a time you will get the MR or TR velocity in lieu of the aortic velocity. So it's why it is also important to look at the duration of the signal. You see that the duration of the signal, the TR velocity, is pretty long, 410 milliseconds, whereas it is around 320 in the true aortic jet velocity signal. So if despite all these efforts to validate the accuracy of the measurements, you still have a discordant gradient with a small valve area and a low gradient. And you have the three situation, the classical low flow, low gradient first with the reduced LV ejection fraction. What do you do? What do we have in the guidelines? This is the CTS guidelines published in 2017. So for this classical low flow, low gradient AS, what they recommend is to do a dobutamine stress echo. And if the patient has some flow reserve, some increase in stroke volume, more than 20% increase, and develops a high gradient during dobutamine, well, then there is a class 1 indication for valve replacement. On the other hand, if you have no flow reserve, not good response to dobutamine, then it's a class 2A if you can confirm the stenosis severity with other modality. And for the first time in the guideline in 2017, they included calcium scoring by CT to confirm the stenosis severity in these patients, in these challenging patients. Having said that, we did this study, which is an analysis of the multi-center TOPAZ registry, and we found that up to 50% of these patients with the classical low flow, low gradient and low EF actually remain with discordant grading at the end of the dobutamine stress echo. And if you look at the main parameter that we have in the guidelines, the MIG gradient during dobutamine larger than 40, you see that a bit less than 50% accuracy to differentiate a true versus a pseudo-severe ES. It's a little bit better with the peak stress valve area measured during dobutamine less than 1, where we get close to 60%, a bit less than 60% accuracy. And it is substantially better if you use the projected valve area at normal flow rate, which is a new parameter that we'll comment in the next slide. So this is a case. So you see a patient with severely reduced LV ejection fraction and low flow state. The stroke volume at rest was 37 ml. And responding very well to dobutamine with increase in stroke volume and LV ejection fraction. The stroke volume is now 51 ml plus 37%. So there is flow reserve in this patient. And the mean gradient at rest was pretty low, was more in the mild range, 14 millimeters of mercury. But with dobutamine, marked increase up to 35. So that's good, but 35 is still not severe. You are not larger than 40. And the valve area was 0.8 at rest and is now 0.81. So this is a frustrating situation, and this is a frequent, actually, situation where you have a discordant grading at rest, you have some changes in the valve area and gradient with dobutamine, but at the end of dobutamine, you still have a discordant grading, and you still don't know which is the true severity. So what do you do in this patient? Well, and this is also the flow rate that we should calculate, which is a stroke volume divided by LV ejection time. And you see stroke volume of 148 is really low. And now with dobutamine, there was some improvement, but not a complete normalization of the flow. And that's why the mean gradient probably did not reach the 40 millimeters of mercury. So what do we do? Well, we will calculate the projected valve area at normal flow rate. So the idea is to project what would be the valve area if the patient had a complete normalization of flow rate, mean flow rate, which is about 250 ml per second. So it's very easy. You have the values of the valve area and flow at rest and at peak dobutamine stress echo. So it's 2-point measurements. And then first you calculate the valve, what we call the valve compliance. It's a big word for actually the slope of the valve area flow relationship that we calculate by dividing the increase in valve area with dobutamine by the increase in flow, in mean flow rate. Again, mean flow rate is stroke volume divided by LV ejection time. So it's delta, the valve area, divided by delta flow. And once you got this valve compliance, you will report in this simple formula here, valve area at rest plus valve compliance multiplied by 250 minus flow at rest. And this patient had a projected valve area at 250 ml per second of 0.82, confirming that you have a true severe ES. So this is a useful parameter to calculate when you get this persistent discordant grading at the end of the butamine. So what do we have now for the other category of low flow, low gradient in the guidelines? A paradoxical low flow, low gradient with a preserved EF, but a low flow defined in the guideline as a stroke volume index lower than 35 ml per meter square. Well, if the patient is symptomatic and if you can confirm the stenosis severity, there is a class 2A recommendation for valve replacement in the guidelines. And the guidelines in 2017 provided this algorithm for these patients with the low gradient small valve area situation and preserve the EF, or reduce the EF actually. So if you have a low gradient and the valve area is large, of course, this is moderate ES. If you have a low gradient with a small valve area, so the discordant grading, well, the first step, as we covered during the first part of the presentation, is to rule out measurement error, confirm the validity of the measurement. Then define the flow status by looking at the stroke volume index for body surface area. If the flow is normal, so more than 35 ml per meter square, this is the normal flow low gradient ES, the guidelines conclude that the severe ES is unlikely. I would somewhat disagree with that. There are some recent studies suggesting that a substantial proportion of these patients with normal flow low gradient may actually have severe ES, and if they are symptomatic, they may benefit from AVR. So I would apply the same algorithm than the other patients with low gradient ES. If you have low flow, then you look at the LV ejection fraction. If you have reduced LV ejection fraction, that's a classical low flow, dobutamine stress echo is the way to go. And if there is significant flow reserve then, and the gradient increase above 40, you can differentiate a pseudo versus a true severe ES. If there is no flow reserve, well, or limited flow reserve, you will probably have no conclusion at the end of the butamine. And this is where you should consider other imaging modality, the calcium scoring, using a non-contrast CT, very simple imaging modality is very helpful. If there is preserved LV ejection fraction, such as in this patient on the right, well, we should use an integrated approach that is described in this table. And this table actually provides the parameters that increase the likelihood of having a true severe ES in these patients with low gradient ES and preserved LV ejection fraction. Of course, if you have a low gradient, but the gradient is between 30 and 40, you have higher likelihood that the stenosis is severe. Same if the valve area is lower than 0.8, if you have a low flow, stroke volume index lower than 35. But the more definitive parameter is, again, the calcium scoring. And it is recommended to use different cut point in men and women. So if you have a calcium score that is larger than 2,000 in men, 1,200 in women, this is consistent with a true severe ES. And again, this is a non-contrast CT that you need to use. So in conclusion, in these patients with low gradient ES, there are 3 steps. First, confirm the accuracy of the measurements, as we'll see in the next slide in the checklist. Second, define the type of low gradient ES. Is it a classical, a paradoxical, or a normal flow low gradient ES? And finally, of course, confirm the ES severity. So this is a checklist to confirm the accuracy of the measurement, which is a very crucial, important step. For the LVOT diameter and area, you can compare the LVOT diameter that you measure in the patient with this simple formula that predicts the LVOT diameter for the body surface area. You could use other modality, 3D, TTE, or TE, if you have good image quality, CT, to measure the LVOT area. For the stroke volume, there are other methods. You can measure the stroke volume, the total stroke volume by biplane Simpson, 3D TTE, or CMR. And there is a low flow state if the stroke volume index is lower than 35 ml per meter square. For the valve area, I like to systematically look at the velocity ratio, the Doppler velocity index. It is severe when it is below 0.25. Don't forget to index the valve area for body surface area, especially in small patients, because a small valve area in a small patient may correspond to a non-severe ES. And you can do the planimetry if you have good image quality by TTE or preferably by TEE. But remember, this is not the same thing as the effective orifice area that you obtain by a continuity equation. This is the anatomic orifice area and will be generally larger than the effective orifice area. So if you have 0.9 with effective orifice area and 1.1 with anatomic orifice area, the stenosis is still severe. And also you can use this hybrid CT/Doppler valve area, but remember to use larger cut point, 1.2, not 1. And for gradient, I just have one recommendation, but it is important, multi-window interrogation. Don't forget the right parasternal border. And for confirming the stenosis severity by different imaging modality, well, first look at the valve. Assess the morphology of the valve by TTE or TEE. If you have severe valve thickening, calcified, and reduced mobility, this is consistent with severe EF. Dobutamine stress echo, especially in those patients with reduced EF, is useful. Look at the mean gradient, the valve area, and projected valve area if you have discordant grading at the end of dobutamine. And for those with low flow, low gradient, but preserve the ejection fraction, as well as normal flow, low gradient, if they are symptomatic, use calcium scoring with different cut point in men and women. Thank you very much, and I encourage you to join the Council on Valvular Heart Disease. Our membership is growing exponentially, and we need your membership. Thank you very much.
Thank you, Philippe. Very nice presentation. A complex disease, but great presentation summarizing. Questions for Dr. Pierrot? Philippe, I think you mentioned very nicely, I mean, the components of where errors could go. The other one I'd like you to mention is the location of pulse Doppler, because the TVI just below the aortic valve is also crucial, and a small error really can be quite misleading.
No, absolutely, absolutely right. Given the time, I skipped the slides, but I agree. The sample volume should not be too far in the ventricle because you're going to underestimate the velocity. Should not be too close. We're often tempted to be close to the valve because generally you have a nicer signal, but you have to be careful because if you start seeing some clicks on your pulse wave Doppler signal, it's probably because you're too close to the valve. You don't want to be too close to the septum because you have some acceleration. So it's tricky indeed. And what I do generally when you get the stroke volume by Doppler in the LVOT, I try to see if it makes sense with the ventricle that I have, the dimension, and the LV ejection fraction. If I have a low stroke volume with a normal size ventricle and a preserved LV ejection fraction and no MR, there is something wrong, right? And then we go back to the velocity or diameter.
This is a crucial point. Yes, question in the front.
I know this is a echo talk and not a CT talk, but I was interested to see the different cutoffs for men and women. And I wonder if that is exclusively mediated by body size or if there are other factors. And the reason that's not just an academic question is if you had a small man or a large woman, you might choose to adjust that cutoff.
No, absolutely. I think we look into that. Actually, Marie and Nick look into that. Because when we had this difference in the cut point, we said, of course, women have smaller annulus, so you need less calcification to reach hemodynamically severe. So we indexed, I did not show the data, but we indexed the calcium score for the cross-sectional area of the aortic annulus. And this is what we call the aortic valve calcium density. And surprisingly, there was still about the same difference. And if you use the calcium density, so calcium score divided by cross-sectional area of the annulus, the cut point to define severe ES are 500 in men and 300 in women. So you still have an important discrepancy. And the explanation, the mechanistic explanation is because women are different from men, you know that? So women, actually, in the pathophysiology of the disease, they develop less calcification, but in counterpart, more fibrosis. Valvular fibrosis, and the fibrosis contributes to the hemodynamic severity, but it's not visualized, it's not captured by CT.
Thank you.
Thank you very much, Dr. Pierrot. Wonderful presentation.